Thank you, everybody. And again, just a big thank you to Eric. This is a ton of work that goes into this, and we appreciate all you do for this, Eric. So I'm going to transition today and talk about a topic that's near and dear to all of our hearts, and probably one of the most common things that in the audience we treat, which is ACL injuries. And one of the foundational topics of that, as you talk about addressing and fixing ACL injuries, is what graft are you going to do, and how do you actually talk about restoring the function of the ACL? So it's a big topic. We're going to kind of take this topic and then go into a discussion that we would love interaction and love comments and questions and talks, because you're going to see there's a lot of different ways to approach this. And I'm going to try to give you an overview, and then we'll dive into a lot of the details and use that to facilitate the discussion. So disclosures are listed, but none are relevant to this talk. So, as we kind of alluded to, the ACL is an important part of the function of your knee, and involved, really with the preventing anterior tibial translation as well as the rotational stability of your knee. There's two bundles of it. So in general, your intermedial bundle is your bundle that provides restraint to the anterior tibial translation, and then your posterior lateral bundle is what controls rotatory control. And the function of this ACL is paramount to then talking about how do you restore that with a graft, or how do you restore that with an ACL repair. So understanding the very basics of this is a big part of then kind of using that as a foundation to talk about how do you fix that. So let's see, Brandon, can you play that video for me? Is that
just hover over the picture and it should go.
Oh, I got it. Okay, my fault. So ACL tears are common, right? Often a valgus injury. So as you see Clay Thompson land here, he goes into valgus. You can tell immediately, grabs his knee. This is a classic story that we see and hear all the time in the office. Many patients will have a pop. They will often have pain, inability to bear weight. They'll have an effusion that will form. Not everybody. You can sometimes be fooled, and certainly for a more subtle or a subacute or chronic injury, many patients will come in and won't have much of the story, and they say they kind of rested it, iced it, were told it was an MCL sprain, and then show up to you. And so you have to kind of really have a higher index of suspicion and really trust your imaging, and most importantly, trust your exam on this. So, your kind of gold standard for an ACL tear is a Lockman exam, which is pictured in this kind of top right image, where you're having the knee at about 30 degrees of flexion and doing a test for the function. But most importantly, the kind of gold standard would be testing a pivot shift, which would be the bottom right video, where we're kind of going from extension to flexion. You see there's a pretty aggressive pivot shift, which what we'd call a pivot clunk. Very few patients will tolerate this awake, but in the OR, this is really the confirmatory test that we're doing. But many with good relaxation in the office will allow you to do this. And so checking for a pivot shift in the office, especially in kind of that subacute or chronic setting, is very important to really evaluate the function of this, because you can have patients who have an ACL injury or even after a reconstruction that they have a reasonable Lockman exam, but they may not have as much rotatory control. And so checking your pivot is a big part of that. As with everything else in orthopedics, we'll obtain imaging. We'll see negative X-rays, but you can pick up Sagond injuries, which are an injury to the anterolateral capsule, and they'll have like a little fleck or an avulsion injury. Even just this week, I had a whole thing where the ER called this an avulsion fracture and non-weight bearing and all this stuff, and this is just a sign of an ACL tear, and pretty much is pathognomonic for that. MRIs are important, looking for both the structure and the integrity of the ACL itself, but you can look for bone bruises, most classically a pivot shift bone bruise, where you'll look at the bone bruise on the posterior lateral tibia as well as the central aspect of the femur on the sagittal cut. And then really in revision settings or settings where you're worried about alignment, would you be thinking about CAT scans, looking at prior tunnel placement, tibial slope, things like that. So those are not commonly done in the isolated setting. And, look, I would say that taking care of ACL injuries is all about having different things in your toolbox. And in 2025, you need to be able to not only address just the ACL, but addressing the ACL involves treating multiple parts of that injury. An important part of this is repairing meniscus. So we're increasingly seeing the importance of not just removing or trimming the meniscus, but repairing it. and the importance not only for the long-term health of that joint, but also the importance of the meniscus on stability, especially as a secondary stabilizer to the ACL. We also have to recognize combined injuries. So for patients who have LCL tears or posterolateral corner injury, just doing an isolated ACL tear because that's in your wheelhouse and that's what you do most commonly, those have a much higher risk of failure. So identifying the patients who have a posterolateral corner injury, very important to both identify it, but then also address it. And then, as we will kind of dive into, hopefully in some of the discussion, we're leading towards an ACL plus surgery. And there's a lot of patients who, even with perfect surgery, have a reasonably high risk of a repeat injury. And these are humbling as surgeons, and we have to start talking about addressing not just kind of a central axis of their ACL, but also addressing their lateral instability. And so adding what's called either a lateral extra-articular tenodesis, or LET, or an ALL, which is an anterolateral reconstruction, are coming into the lexicon and certainly into the repertoire as surgeons in 2025. And this is the toolbox that we have to approach patients who have ACL injuries with. Because just addressing their ACL is kind of a myopic view of their injury, and understanding not only their ACL, but their impact on the meniscus, the cartilage, as well as the other ligaments and the capsules around their knee. That's the way you, in a multifactorial manner, address the whole picture and have kind of the best outcomes and the high-level outcomes. So, as we step back and kind of say to ourselves, well, how do we get a successful outcome to an ACL surgery? It really is a multifactorial problem. And graft choice, which is kind of what we're going to deep dive into today, is one part of that. But this is a team approach, and as a surgeon, there's things that we can control. Most importantly, it's doing a good meticulous surgery. It's addressing the other concomitant parts of their injury. And one of those things is a graft choice discussion. And so I'm going to use this kind of as a pivot into that. But frankly, as surgeons, we can steer that discussion, and this has been looked at with a lot of studies, based upon what we think is probably best for that patient. It should be a shared decision-making. But in general, we're going to assimilate information. We're going to look at a patient's activity, what their goal is, some of their different anatomic factors, and use that to guide what we think is the right graft for them. And as we looked at other topics this morning, it's really not a one-size-fits-all approach. But that's the kind of important discussion. And as athletic trainers and therapists, a lot of times you will be part of that, and many times facilitate the decision-making for that patient as far as what's the right graft for them. But that's just the surgeon part of this, right? There's the patient part of this, which is really the compliance to the rehab, the understanding of what they need to do. And a lot of this is the psychology of that athlete, and really the grit to respond after an injury. And this is something we're seeing more and more, that the softer parts of our job, so to speak, talking to a patient about how do you respond after an injury, how do you get through the pain, how do you get through the initial rehab process. These are important parts of our job, because being a surgeon is not the full picture for this. We have to be able to navigate that patient through their recovery, through their surgery. And then that's done in a team approach. So working with your athletic trainer, working with your physical therapist, they're a huge part of this. I think we would all agree that, probably maybe half of the recovery of this is the surgery, but a huge part of this is the rehab and the strengthening and all of the parts of this that aren't really going to be a big focus of this talk today. But, this graft choice decision really fits into that bigger picture context, because, depending on which graft we use, it does impact the rehab and it does impact the initial recovery, and it's a big part of kind of treating that patient in a holistic approach. So one of the things I think we maybe don't want to forget is, well, what are the options, non-operatively for an ACL injury? And, commonly we're going to fix these, and a contact high school athlete who has an ACL tear, I don't think any of us are going to recommend non-surgical treatment. But there are a number of people who show up who, as you get to know them and you talk about them, their demands are lower. They may be in their mid-50s or so, and have a proximal tear. Those are very reasonable people to try non-operative treatment. That is done in the form of physical therapy, sometimes bracing. And in general, we fix ACL injuries to help prevent the risk of future meniscus and cartilage injuries. But when you truly talk about the arthritis risk long-term, That's not something we're changing with the ACL surgery. It does stand to reason that if we can limit their cartilage risk in the future, they're going to limit risk of arthritis. But truly, the studies, we don't do this to prevent arthritis, which is, I think, a misnomer. We do this to restore stability, give them a stable knee, and prevent the future meniscus and cartilage injuries that we know will happen with non-surgical treatment for patients who want to play a pivoting and cutting sport. So non-operative treatment is certainly an option, but not the go-to for most of the people that we see in the office. And, ACL reconstruction is that go-to, okay? That's the long-term gold standard, which involves taking a graft, that can be both autograft or your own patient's tissue, as well as an allograft, which is a cadaver tendon, and use that to reconstruct or replace the function of the ACL. How you do that, which is either with different fixation methods, buttons, screws, other kind of devices. These are all somewhat dealer's choice, and you can do a successful ACL in a number of different ways. But from a foundational standpoint, an ACL reconstruction is really one of the most important things that we talk about to giving a good outcome after an ACL injury. And as we alluded to, and we're going to dive into the graft discussion, there's two basic headings. Your autograft tissue, which is using your own tissue for the graft, is really the gold standard and the choice for athletes in high school, college, and elite level athletes to use for their graft. There's, as with many things that we've talked about this, the pendulum does swing back and forth, and there was a big push towards a faster recovery and less pain and cadaver graft for young athletes, probably 20 or so years. But we saw the failure rates for that, and in general, a failure rate for an adolescent athlete who has a cadaver tendon is about 40%. And that's just not something that we should be doing. And so, I'd strongly encourage the use of autograft tissue. And then within that heading, this is where you're going to talk about some of the different pros and cons and some of the experiential part of this. And we're going to talk about basically the three main options of patellar tendon graft, quadriceps graft, and hamstring graft. So there is a role for cadaver tendon or cadaver graft, but most of us are going to be utilizing that for our lower demand patients. Certainly, it's a little easier recovery up front. I think we would all agree they tend to have less pain, but most of the time we're going to be doing that for lower demand patients, but it can be a very good option. And the data, the literature in general would say over the age of 40, you would have a same outcome as you would for autograft tissue. But I try to tell patients, it's really about treating, function more so than age. I'll have 50-year-olds who are more active than, half of the 30-year-olds that come in my office. And I have the opposite is true, where some 30-year-olds are very low demand and maybe a perfect candidate for a cadaver graft. And so it's all an individualized approach. And, as we get into the discussion, I think you'll hear our different approaches to that topic. So within the autograft tissue, there's kind of three main headings. And I would kind of submit to you that probably the longest standing track record would be in the patellar tendon graft. And I would say for the most of us, this is probably still considered our gold standard for a couple of reasons. One is you give bone blocks on either side of the graft, which really allows bony healing, which tends to be faster and a little bit stronger, and is kind of our go-to graft for our money on the line patient. You got that high school or college football, soccer, lacrosse athlete. In general, this is my go-to graft and is a strong graft, but does come with some downsides. This is a little more painful surgery. The biggest thing we worry about would be patellar tendonitis and kneeling problems. And we'll dive into this in some of the discussion. But this is a great graft and it's got a lot of longevity and decades worth of research on it. And certainly an important one to have in your armamentarium of treating ACL injuries. Next would be a quadriceps tendon graft. And this is, in the last probably 10 or so years has become more popular and, involves both taking a bone block off the superior part of the patella or just an all soft tissue graft with suspensory fixation. And these are all good options. And in general, the re-tear rates are about the same as your patellar tendon. The pro is going to be the kneeling issue and the patellar tendonitis, because obviously you're not taking part of your patellar tendon as your graft. And the other big pro is you don't have to worry about the physis. So for younger patients who have open growth plates, this is a good option because you don't have to think about their tibial tubercle physis. The downside is quadriceps, you're taking part of your quadriceps tendon. So the potential for quadriceps weakness is especially early on, which is one of the tenets of ACL recovery. Get the quad activated, get full extension. These are all hallmarks of rehabbing an ACL surgery. And so my experience with the quad is that it tends to be a touch slower in that, probably about a week. But overall, when you look at quadriceps weakness, they normalize as you return an athlete back to sport. And this is a very good graft and has great indications for the right patient. And then finally, from an autograft tissue, you have your hamstring tendon, hamstring tendons. And so this is a long-standing graft. Again, it's been around for decades and still probably in Europe would arguably be the go-to graft for many surgeons. And so this is a great graft. One of the concerns is we always say you can't pick your hamstring size, so they are what they are when you harvest them. When you have patellar tendon and quadriceps graft, as surgeons, we can choose the size of the graft we're going to harvest. And so, typically we're trying to get at least above an 8 millimeter graft. But usually we're shooting towards a 9 or 10 millimeter graft in diameter. The hamstring tendons are what they are when you harvest them. So patients who have smaller hamstring tendons, you can do techniques to kind of fold the graft on top of itself even once or twice, called a tripling of the graft, to thicken it. With that, you lose some of the length of the graft. But still, this is a good graft, but the concern is over time, and some of the data is that these can stretch. And so especially hyperlax female athletes, this is something we try to avoid and often will not use for a competitive athlete who has that kind of profile, but still very much in the armamentarium as ACL surgeons that we would do that. And as we've alluded to, things tend to be a pendulum and they can come around, and there's definitely been a resurgence of ACL repair in the last probably 5 to 7 years. And ACL repair is an idea that instead of taking out your ACL and reconstructing it, can you keep your own tissue and allow it to heal back to the bone? As you look at other ligaments in the knee, the MCL being the kind of the poster child for this, we almost always leave an MCL alone, and they do fantastic. And so the question is, why can't we do that for the ACL? And there's a number of things that maybe speak to that. The biggest thing is really the intra-articular environment of the ACL. And the ACL is inside of your knee, so it's bathed in synovial fluid. And that really tends to prevent it from healing versus your MCL, which is outside of the joint, and a hematoma or clot will form. That body will remodel that, and almost always an MCL does very well except for the high-grade or combined injuries. So, there's a lot of potential benefits or reasons we try to keep your ACL, most importantly, the potential proprioceptive benefit. But historically, the challenges were, did it work? And as with Dr. Gatt's discussion earlier, follow-up is important because the early data of open ACL repair back in the 70s in our military population was frankly fantastic. People did great at 2 years. We said, hey, this is a solved problem. But as we looked at follow-up into the 5-year outcome, this was humbling. And if you look at kind of the bottom right part of this slide, 94% of patients had instability at 5 years. Okay, that's not great, and we can do better than that. And pain, swelling, stiffness, and so ACL repair was, for some extent, abandoned. And kind of the era of ACL reconstruction came about in the early 90s as arthroscopic techniques and arthroscopic instruments became more common and developed, and we got better at that. And ACL repair kind of went by the wayside. But this idea has been worked on and thought about, and still there's a lot of potential benefits for it because you can keep your own tissue. You don't have to take a graft. And so it's been looked at over the last kind of 15 or 20 years. And very excitingly, this has been kind of brought from the bench to the patient's surgery. And there's been a lot of data up in Boston led by Martha Murray for the idea of an ACL repair. And you can do an ACL repair, or you can do an ACL repair and augment that healing with a scaffold. And that's kind of the idea of this bear procedure. And in general, this is a very exciting time to be an ACL surgeon because this is another option for us for a well-indicated patient. And what I talk about with patients as we look at the data at this point in 2025 is that we have good data that a bear repair really the term would be non-inferior to a hamstring autograft at 2 years. Okay, so we have short-term outcomes, and that should be met with caution because we just looked at the history of this. How does it hold up over 5 years? We don't have that data yet. It's coming out, but we don't have it yet. But a repair is as good as a hamstring autograft at 2 years. And that's an exciting thing because you don't have to take a graft. You don't have to worry about the morbidity of that procedure. And you can allow the body to heal with certainly potential improved proprioceptive parts of it. So there's a lot of kind of push, and this is an important part to add to the discussion of what's the right graft for a patient. Because certainly in a well-indicated patient, I think this is a great option. But it's a big discussion with that patient because we just don't have the 10 or 20-year outcomes for this. And then as we talk about other specific characteristics, grafts have to take into account what are the specific parts of that patient. And one, most importantly, is, is the patient skeletally mature or do they have open growth plates? Because if they have a tibial tubercle that is open and they're a 12-year-old or 13, 14-year-old male that doesn't have a lot of secondary sex characteristics, that patient's got a lot of growing left, and we're not going to take a patellar tendon graft for them. And then we have to cross the growth plate to do their surgery, and so there are alternative ways to do that, both a physeal sparing approach or a transphyseal approach. Do you put the bone block across the growth plate? How do you do that? And so there's a lot of parts of treating ACL, and this is a whole topic in of itself. But choosing your graft has to take into account what's the status of their growth plates. So I tried to do that as a little bit of a background and maybe a springboard into a discussion point. So I think at this point, I'll ask my colleagues, Dr. Barrow, Dr. Swan, and Dr. Gatt to come up, for a roundtable discussion. So we can kind of talk about, different grafts available to us as surgeons. And I'd encourage you, if you have any questions or have questions for us as a group, please put it into the chat and Eric will feed it up to us at this point.
I was a middle child, so I was used to it.
All right. How are we doing, Eric? Any questions at this point? Okay, good. All right. So, let me just start out because obviously as we talk about graft options, it's really a discussion of weighing pros and cons. So, Dr. Gatt, talk to me about when we talk about a patellar tendon graft and, the pro-con scenario, we often will say patellar tendonitis or kneeling pain. What's your experience with, do you think that's overblown? Do you think that's a real thing? And how do you manage that if that does happen to you?
Yeah, I think that conceptually patellar tendonitis is overblown for sure. I mean, the patellar tendon is my go-to graft, and I have very, very few cases of chronic patellar tendonitis that are challenging. The anterior knee pain is something that is, I think it's almost part of the recovery in many cases, and I just kind of tell the patients that once their quads get back and they have better knee mechanics, their patellofemoral pain will resolve. Interestingly, going back a long time to one of the randomized prospective studies of patellar tendon versus hamstring reconstructions, really one of the originals, they show no difference in anterior knee pain. So it's also debatable whether that anterior knee pain that we see is graft related.
What do you do in surgery, Charlie, to try to limit that? What are your techniques to try to help that?
So I try to be very careful with the harvest of the patellar bone block. I never use a mallet. The bone block is harvested with an oscillating saw, pry the bone block out very carefully. I'm very particular about preserving the peritoneum of the patellar tendon so that once I've harvested the graft, I sew the peritoneum back over the repair. I also bone graft the patellar defect. And I was at one of the AOSSM meetings where, unfortunately, they never published the data, but they did a randomized prospective study of grafting and non-grafting the patellar defect and showed that there was less anterior knee pain with the grafting of the patellar defect.
Sure.
So, those are the grafting, peritoneum care, and very gentle harvest from the patella, I think help.
Dr. Swan, so let's pivot to the quadriceps graft. So same question, what's your experience with quadriceps weakness as you have, grown and indicating that graft more? What do you like to do in surgery to try to limit, complications or morbidity from that graft?
So it was exciting when the quadriceps graft became more of an option, maybe about 10 years ago or so. It just gave us another tool on the shelf to use in particular patients. I do like that graft. I think you can get a very big, thick graft. The length of it is something that can sometimes be challenging depending on the size of the patient's quadriceps muscles around the tendons. Sometimes you can't get maybe as much length as you want. So that sometimes then requires a little bit bigger incision to get all the way up the thigh. So that's not necessarily ideal, but you have to do what you have to do to get a good graft. And then it's been very helpful to use this graft in, I think, some people who will be kneeling a lot. We talked about kneeling pain. So if someone is going to be a carpenter, someone who prays a lot, is on their knees daily for prayer, it's not comfortable to kneel after a patellar tendon autograft in some people. So that's why quad tendon may be a good graft for that scenario.
All right, and then Dr. Barrow, have we forgotten the hamstring graft? What's your indication for this? I would say that if we were in France or Europe right now, I think we would be having the opposite discussion and saying I do a hamstring graft everywhere. But in America, it's, I think, less common. What are your thoughts on that? What are your indications for a hamstring graft in today?
So that's a good question. Definitely hamstring grafts were a lot more in favor, say, prior to the 10-year quad tendon boom that we're now in. And there are many different ways to develop a hamstring graft. So you can use it having a quad hamstring graft, doubling the tendons over. You can actually double them more than 4 times. You can do that about 6 times and make a smaller soft tissue graft held by suspensory fixation. And so I think, personally, I don't really use hamstring tendon as much, but I did use it a lot prior to the quad tendon switch. But I do think it is a strong, viable option if you do need a soft tissue graft. And as well, if for whatever reason you can't use the quad tendon or bone tendon-bone, I do think it's an acceptable option as well. My only concern with it, again, going back to some of the literature, we look at some of the Norwegian registries, which kind of show that there is an increased risk of infection and failure rate with hamstring graft compared to BTB. So I think people have moved away from hamstring grafts for that reason and moved more towards like soft tissue quad tendon if they do need something else.
Good, all good points. Go ahead,
Question from the audience: if using a hamstring graft, what are some things that PTs and athletic trainers need to be mindful of during the initial post-op therapy to facilitate recovery?
So I'll pick that
Chris,
up.
why don't you go? Yeah.
Yeah, so you have to be worried about flexion strength being affected. So even though the hamstrings are more kind of like accessory flexion tendon muscles, we still look at them as affecting about a 10% loss in flexion strength as opposed to extension strength. So we're really going to have to work on or focus on some of those exercises.
I don't change regardless of graft, I never change my rehab protocol. It's the same, so I don't really modify the rehab protocol if it's a hamstring versus a patellar tendon or a quad. But the one thing that I will tell you that's happened over the years is that as the patients are going through the recovery, and I'd say it more often than not happens in the 4 to 6 week range, they're doing PT or their own rehab and they feel a pop in the back of their leg and they freak out because they're sure they tore their ACL graft. What they probably did is pop an adhesion from the site of the hamstring harvest. So I've talked to a few people off the ledge over that one.
Brandon, can I go back to the presentation we're going to go through maybe some case here to facilitate some discussion. So, okay, so we're going to kind of go through a case or a couple cases here. So for the group, we have a 21-year-old male who's a collegiate wrestler. He's a senior. As with many wrestlers, he kind of had an injury and then basically ignored it and tried to play through it, but comes to you saying, hey, I can't wrestle after about a month of trying to do this. Feels his knee loose, feels it buckle, has a pretty obvious exam, in the training room of the office. This is an ACL tear, college wrestler. Let's go across the panel. What's your graph for this, Dr. Gapp?
I probably I'd hamstring, but I might lean towards quad.
Okay, why?
Forward. Because the wrestling, when they're in the referee's position, the kneeling pain could be an issue.
Okay. KG?
I agree.
Chris?
How big is he?
He wrestles at 160s. He's not like a heavyweight.
I would definitely lean more towards quad.
Okay.
The heavier they are, I tend to use more of a bone block.
Yep.
Somewhere in the middle, I'd think about soft tissue quad.
Okay.
And if they were a 105 pounder, that's a little, they may have
Small
little
toe.
hamstrings, and that's one that we probably would lean away
Sure.
from hamstrings.
So wrestlers, in general, most of us would agree probably away from a patellar tendon graft for the kneeling risk of that. Okay, so then we get an MRI on the patient. So I think hopefully you guys can see this here in the room. Let me play this here. So this is your MRI, sagittal cut. Okay, so we have classic bone bruise pattern. We have a femoral-sided ACL tear that I'll stop here in a second. So you have a pretty reasonable looking ACL, and if I were to maybe take a couple screenshots of it, you have a tear off of the femur, but have an MRI that looks like that. And again, their exam is very impressive. Okay, they got an obvious ACL deficient knee. Does this change anything for any of you? Dr. Gatt.
Well, obviously, with the femoral avulsion type injury and such a great looking ligament, you start to think about, is there a role for Baer? And the problem with it's a perfect case, from the standpoint of anatomy, but it's a collegiate wrestler who, I don't know what his eligibility is and things like that. But,
1 more year.
Yeah, so, we don't really have, I think, as a general rule, Baer has been a little bit self-selected by surgeons for the lower demand patients. So if you do a Baer on this kid and he fails, now he's been right back to where he started. If you do a quad on this patient and he fails, you kind of defy, that would be, that probably has a good outcome. You're not really have the evidence to support the use of a Baer, but it's certainly an option.
Okay, so then you get into surgery, and this is what you're looking at. So you have a viewing from the anterolateral portal, you have a probe here in the ACL, you have a really robust looking ACL that's pulled off of the femur, and you can see that that's why his function isn't there. So, Dr. Swan, thoughts on this at this point?
I mean, I agree. It looks like one that you might want to do a Baer on, and certainly in the right patient selection is key. That's a good Baer candidate in the right patient. But a wrestler who, I don't know what he's doing afterwards, if he wants to try and wrestle, is he Olympics bound? Is he going to turn over to jiu-jitsu in his 20s? He may be a very active guy who may abuse this knee, and I would probably go to my go-to and use a quad.
Okay.
As good as that looks.
Dr. Barra?
Same thing. I think is when other factors kind of come into play. Is there any meniscal pathology that might benefit from an ACL reconstruction per se?
Mm-hmm.
What are they doing afterwards? Are they going to the Olympics, the WWE? Like what are their future plans? Are they just going to go work in like Wall Street or something like that? So I think if you take all of those into consideration, I'd consider a Baer very strongly.
Yeah. Yeah, so I think this is a long discussion with a patient, right? And this is where you have to admit, which is not something we do every day, like what do we not know in the world and what do we know? And this is one of those things that the patient had, many times patients are aware and they done their homework, and this is one that we had a long talk about what are the different options and what are the right grafts, and this patient was very interested in the idea of a repair, and so that's what I did for him. So this is, again, you can go a lot of ways with this case, and I think there's a lot of ways, and you have evidence to support it. So I did a repair on him, and this is in probably the first 10 or so that I've done, and he had some vague complaints at around 6 or 7 months, which many of them do. So I used that as an opportunity to get an MRI. And a great looking graft. He had a great Lockman. And basically he did very well and was able to return to wrestling the following year. He actually came back and wrestled against Princeton. They did really well that day, but the one match that was won against us that day was by this athlete wrestling for the 5th year that they can't do in the Ivy League. So he got back to wrestling and then that was the one weight class that was won that day that wasn't Princeton. So anyway, this is, I think, a really illustrative case because you can approach this a couple different ways. And it's very much coming down to that discussion with the patient, that discussion about what's our literature say, what are the pros and cons of that, and I think this is a nice case to kind of talk about that.
For sure. Nice.
All right, so how about case number 2? So we have a 20-year-old male who's a collegiate lacrosse player. He's a junior, wants to play 2 more years. He had a pretty classic story, non-contact pivoting injury. Swollen, but concerning Lockman, doesn't have any clear signs of a collateral injury on your exam. But as you get to talking to him, so he's from out west, and his dad had torn his ACL. His sister had ACL tear on both knees and had a revision on one. So this is a family that gets it, and they've kind of been through this. And this is your MRI here on the sagittal cuts. So you have a bone bruise pattern here with a lot of edema of the knee, even looking at the back of the knee. Complete ACL tear there. And as you go to the medial side, some bone bruise pattern of that. And on the coronal cuts, you have, again, edema, but there's an intact LCL that feels really good on your exam as you check that, but has a proximal MCL tear from this injury. So if we summarize, is an ACL tear. He's got a lateral meniscus tear, which is maybe a little hard to see on the screen, proximal MCL, but more edema than maybe you would typically see. So, Dr. Barrow, what's your thoughts on this for a collegiate lacrosse athlete with using a graft for this?
Well, I definitely think autograft, basically looking at his MRI cuts. So I would personally do a quad tendon with a bone block.
Okay.
I'll stop there because I know what you're going to probably ask.
Okay, Dr. Swan, so same question. Should we be thinking about anything else with this athlete? What's your indication for an ACL alone versus adding any extra-articular procedure?
Yes, so his activity level, his family history, and then sort of the violent nature on his MRI. He's had a pretty significant injury, not just a simple little twist and pop that didn't cause as much swelling or edema. So it does raise some concerns. The MCL injury, his knee may be a little looser long term, so I would use an autograft. I'd probably do a patellar tendon on this athlete, and then your question, is a lateral extra-articular tenodesis indicated? I think it's a very good question, and I would strongly consider it. I think the family history, I mean, he got to age 20, he's been playing lacrosse his whole life. Yes, he has a family history, but he's also just been playing a lot of sports for a long time, and he dodged a bullet for 20 years. So I don't know if I could say that he truly has such a strong genetic component, but they get it, they understand it. It doesn't add that much to the procedure, so I would strongly consider an LET.
Okay. Dr. Gatt, same question to you.
I'd start off with just a patellar tendon. One thing about these knees, is lateral meniscus, is that a peripheral tear?
He's got like a vertical posterior horn lateral tear, yeah.
Okay. I mean, it depends how, I would like to let that MCL tighten up a little bit before I went and did his ACL.
Mm-hmm.
I have to kind of carefully look at the meniscus, decide if I'm going to push the limits or try to get in early, but for the most part, I think a good BTB ACL reconstruction do very well for this guy.
And what would your timing be for for the MCL component of it?
I'd probably try to wait, 4 weeks,
Okay.
maybe between 4 and 6.
Okay. So this is what I did. So surgery at 4 weeks. I did a patellar tendon autograft on him, repaired his meniscus, but I did do an LET. So this is a discussion, and this was, very driven by the experience of the family who's already went through this with their daughter and said, hey, look, what are the options to try to limit this for a high-risk athlete? And this is the humbling part. If you look at all of our data on, a collegiate lacrosse player who's got, I would say this isn't your standard ACL with the edema and everything else you got going on. I think this is a very reasonable place to add an extra-articular procedure. Dr. Swan, when you do an LET, how does that change, if at all, your rehab, and what are you doing post-operatively in that setting?
It hasn't changed my rehab. I think the data for LETs is sort of all over the place in terms of how we do it, what position we fix it, what the rehab is, but I haven't let it change my post-operative protocol.
Okay. And what, Dr. Barrow, can you maybe talk to me about like some of those factors of doing an LET, and what do you think kind of matters as you're fixing it, and what position you have the knee in, et cetera?
Yeah, absolutely. So I think it was a good call, particularly with an edematous PLC, as you showed before. I think some of the recent biomechanical data has shown that LETs do afford some restraint to varus laxity. I know there's no clinical data on that yet, but I do think it's a good idea to augment. Thinking about the factors that would push me towards doing an LET, so kind of a case like this, family history would also come into play. I think in my hands, usually I'm thinking about LETs and revision work. So if they failed in ACL once for whatever reason, for a variety of reasons, I'm going to make sure that they don't fail again. So LET is pretty much standard now in all my revisions. And we worry about those athletes that are at high risk, like females and young females involved in cutting sports. Those are the ones that we potentially consider LETs for.
So Dr. Gatt, what do you look at on the, like if we're talking about the patient factors, we talked about their laxity, how about the morphological parts of their tibia, their slope, things like that? Does that change how you do indicate an LET?
Yeah, so I think, if you were to look on your lateral x-ray and saw increased tibial slope, it might point me more in that direction. There's a debate now as to whether we should be addressing tibial slope as part of surgery, but to Dr. Barrow's point, it's probably more of a revision type situation. But I think, so if I saw the high degree of tibial slope, I would definitely lean towards an LET versus a slope-reducing osteotomy. I think, it's obviously hard to examine these patients in the office, but when you get into the OR and they're asleep, gauging their pivot shift under anesthesia is a big help. So if it's a pivot clunk, like you described earlier, again, that might be a reason to move forward in that direction of an LET or some form of extraarticular augmentation.
So talking a little bit about patellar tendon, Dr. Swan, so as you're looking at the preoperative variables to try to help you in surgery, one of the things we look at is kind of the length of the patellar tendon. What do you look for as you have an MRI in front of you that would say, okay, this is going to be a straightforward one, or this is something that I have to maybe think about, how I'm going to manage this in surgery? Talk a little bit about that.
For the patellar tendon, so the length of the patellar tendon matters. If someone has a really long tendon, that may change how much room you have to put it inside that knee. So we will have to change our tunnel position and our tunnel angle in the tibia to gain more length in the bone to accommodate that longer tendon. So we'll measure the length of the tendon from the patella down to the tibial tubercle. If it's short, that usually doesn't matter that much. You can change it a little bit if you have to, but you're not so much worried about it being short. But if it's long and you don't accommodate for that in your tunnels, then you're going to have your graft sticking out of the tibia, and that's no good.
Any questions, Eric? We're good?
No, I think we're good. Maybe we can do one more case, and you have one more?
I have two more. I'll go to the more interesting of the two. Okay. 14-year-old football player, high school freshman. Again, the story is kind of a classic thing, right? So felt the pop had this was a contact injury. Came into the office, had an infusion. Hard, as we talked about, to get their Lockman, but basically otherwise a normal exam. So these are your X-rays you're getting here. So Dr. Gatt, kind of talk to me. 14-year-old, you got a young high school football player here. What's your graft considerations? What are you going to use for him?
Well, since patellar tendon is my go-to graft, but he's only 14. His growth plates are starting to close, but his tubercle physis is still open. So I'm probably leaning more towards a quad in him, to tell you the truth. But I've done patellar tendons in case like this without any difficulty. People worry about growth disturbance. At that age, with that level of closure, he probably would be fine either way.
Dr. Swan, same question.
Yeah, I agree. But this is definitely something that we think about, we're concerned about, and you do look at the whole patient. If his X-rays showed that the physis are a little wider, a little younger, then you do want to be talking about his secondary sex characteristics. What does he look like? Is he a mature 14-year-old or a really young-looking 14-year-old? What's his height compared to his parents?
Yep.
All these things come into play, and then can you treat him almost like an adult? Or do we have to be a lot more careful? So in this one, I'd most likely be doing a quad tendon, and then you avoid the tibial physis, and then just have to deal with the femoral physis. And what we sometimes will do is make the femoral tunnel just a little bit more vertical, so it's not going sideways through that physis. But then you run the risk of not giving him as stable a knee, so you have to weigh all these things.
What about an all soft tissue quad?
This guy's good at the all soft tissue quad, and he's still teaching me. So,
Dr.
that
Barrow,
may be a
thoughts?
good question for Dr. Barrow.
So I would echo everything Dr. Swan said about taking all those factors into consideration. Of course, what position he plays. I mean, he looks thinner. I don't know if he's a wideout or what have you, but you know, you want to take like all those things into account. But I would agree at 14, and if he's still growing, I'm considering a soft tissue graft. My first choice would be a quad, but I think hamstring would also work here. The other thing I'd actually be interested to see is what type of ACL injury he has. Is it a proximal avulsion or mid-substance? And I mean, you know, it's a little bit off-label, but at that age, you could consider something like a bear.
Sure. I don't think it's necessarily off-label. I mean, much of the data for bear is the pediatric population. So here's your MRI. Great segue, Chris. I love that. So here's your sagittal MRI. You know, showing his growth plate. He's got one of those MRIs where you're trying to find the ACL, and it's not all that easily found. So I don't think he's a great bear candidate. You know, but importantly, he's got a pretty bad radial medial meniscus tear. You're going to see as it comes around to the back on the coronal image here with a flap or a fragment right there. And so you got to think about also probably a pretty significant meniscus tear in the posterior medial aspect of the knee. So maybe in time consideration. So I did use a quadriceps autograft. He had a root repair, which kind of was a transosseous technique. So you can kind of see in this middle picture the luggage tag sutures, and then I did a all-inside device around that to do a horizontal repair and tie that over a button, which you'll see on the postoperative x-rays. And then as Dr. Swan talked about, I think I chose a quadriceps tendon graft for this patient because of the tubercle physis. I think that, you know, trying to get it a little higher, as we saw with the button there and the lateral x-ray, the lateral femur, is a good idea, balancing stability with growth plate disturbances. But, you know, this was, I think, a good indication for a quadriceps autograft, fixes meniscus. He also had a small lateral meniscus tear at the same time. You know, so again, there's multiple ways to approach this, but this is that, you know, patient and surgeon discussion in the office and talking about what are the different things in your toolbox and how do you address these and how do you approach this kind of an injury. We're good on timing? Okay, good. All right, great. Thank you all very much.
Thank you.